It is now my privilege to introduce Michael L. Main, MD, MBA, MS, Senior Vice President and Chief Clinical Officer, BJC Health System, West Region, President, St. Luke's Physician Group, Professor of Medicine, University of Missouri, Kansas City. Dr. Main.
Thank you, Matt. Good afternoon and welcome everyone to this ICUS webinar on contrast enhanced ultrasound safety, the latest data and observations. As Matt said, I'm Mike Main. I'm also a practicing cardiologist at St. Luke's Mid-America Heart Institute in Kansas City. I'm joined today by three expert colleagues on this topic, including Dr. Jordan Strom, Dr. Casadaga, and Dr. Dirk Liebert. Move on to the next slide. I'd like to extend a welcome to each of you from our ICUS co-presidents, Dr. Steve Feinstein and Dr. Stephanie Wilson. Also invite you to check out our website at icussociety.org. Next slide. We're the only global professional society solely focused on CEUS. We now have members in 85 countries across multiple specialties and multiple disciplines. And the next slide. We are committed to contrast enhanced ultrasound. It's an essential tool for modern ultrasound labs. It's safe, reliable, versatile, patient-friendly, and cost-effective. It produces high-resolution, real-time images of the CV system, major blood vessels, and organ and tumor perfusion. And it often reduces downstream testing. It improves hospital workflows, and it speeds access to diagnosis and therapy. Next slide. We're unique as a society in that membership is actually free. And if you like, you can join right now using the QR code and take advantage of free CME opportunities like this one, our free mobile app, and the ICUS CEUS News Monitor. Next slide. And if you go on and explore the ICUS website, you'll find our 2026 webinar calendar, guidelines, protocols, and training materials, and information on how to establish your own contrast-enhanced ultrasound lab, as well as coding information for reimbursement. Next slide. We also offer IV training and certification for echo and general imaging sonographers, and you can see some of those opportunities there, including free CME. Next one. We'd invite you also to check out the Sonographer Training Resource Hub, which was developed by a joint multi-societal task force, including the societies listed on the slide. Next one. I previously mentioned the Contrast Enhanced Ultrasound News Monitor. That is also emailed free of charge to all ICUS members, and is a really great resource. Next one. Please talk to your colleagues, ask them to join ICUS, and we'd also invite you to follow us on Instagram and Facebook. Next slide. Go on to the next slide. We'd also invite you to join us October 1st and 2nd for the 40th anniversary of the International Double Conference in Chicago. I've been attending this now for over 25 years. It's a great meeting and a great opportunity to learn more about leading advances in contrast-enhanced ultrasound. Next slide. We'd like to also thanking our sponsors, the Diamond, Gold, Silver, and Bronze level. Diamond, Bracco, Gold, GE Healthcare, and Lantheus, Silver, Canon, Siemens Healthineers, and Sonoscape, and at the Bronze level, Denton's, Fat Roman Studios, Northwest Imaging Forums. All right. Well, with that, I will turn this back to Matt Wilson to get the program started.
Thank you so much, Dr. Main. Our first speaker, it's a privilege to introduce Jordan B. Strom, MD, MSc, FACC, FASE, Associate Professor of Medicine, Harvard Medical School, Director of Echocardiography Laboratory, Beth Israel Deaconess Medical Center, Boston, Massachusetts. Here's Dr. Strom.
Wonderful. Can people see my screen correctly? Or not?
It looks black, although it does.
Okay. We're going to just try to figure this out real quick here. Apologies for the...
Here we go, just not in presentation yet. There we go.
Perfect. Okay, great. Well, thank you, everybody, and thank you for the warm introduction. It's really a pleasure to be here, standing with the, such illustrious peers. I think Dr. Main doesn't do himself justice in saying that, but he really has been a pioneer in this field of safety considerations, particularly around sort of contrast use and echocardiography. And so, happy to give you an update. My name is Jordan Strom. I direct the Echo Lab at Beth Israel Deaconess Medical Center, where we do quite a bit of contrast work, and these are my disclosures. So before we sort of dive in, I know nobody likes to have too much specific detail here, but we're going to just do a very brief primer on your immune system, because I think it's relevant in terms of understanding this a bit more. So you have really two types of immune systems. We're born with the innate immunity and adaptive immunity. Innate immunity is sort of the core from the sort of very primordial ooze. That's where that's the source of sort of the initial immune system that we have. It consists of things like skin, which keeps allergens away, but it also consists of these things called complement proteins, and there are different proteins that react to cause histamine release from mast cells and ultimately cause the same kind of cascade that we see in anaphylaxis accordingly. And these complement tools or complement proteins can be activated in and of themselves, based on sort of direct activation in response to seeing an allergen, or there can be an antibody that binds to that allergen, like an IgM or IgG antibody, and that itself triggers this mast cell release. And the reason I mention this is actually the most common form of allergy that we see, or severe allergy, I should say, that we see in response to ultrasound contrast. It's called a complement-associated pseudoallergy or CARPA reaction. And importantly, it doesn't involve prior exposure. So don't have to have had a prior memory of exposure to that allergen. The first time you receive it, you can react accordingly. Sort of in concert with that, or sort of in later evolution of your immune system, we have the adaptive immune system. And that's what people are more used to describing when they talk about the immune system, where you have white blood cells that produce antibodies, and those antibodies bind to antigens or allergens in some cases, and then trigger a reaction. And in this particular case, IgE is a type of antibody that, when cross-linked, can cause mast cell release, and the typical anaphylaxis is due to that sort of IgE-mediated reaction. But you can also, if you happen to be exposed to dirt or bacteria or something that gets into your bloodstream, you can also develop an immune response to that. And then the initial phase of the immune response is what's called IgM, or sort of early mediated forms of this. And you have a rise and fall in IgM as you build up the IgGs, which are the more sort of chronic sign that you have some immune exposure to an allergen. That's it. So just to understand, there are two different pathways. CARPA is the more traditional pathway we see for immune reactions, but we'll talk about adaptive immunity as well. All right. So ultrasound contrast in general is a very safe type of agent, a class of agents. They are, however, associated with a CARPA reaction that's very rare, but it occurs in about 1 in 15,000 cases. And as a result, we have to be prepared for that. So IEC policy is for Echo Labs to have a policy on early identification and rapid response to these severe reactions. And then it's really everybody in your lab needs to be trained on how to identify those and what the procedure is within your laboratory for rapid response to these. That's so that if somebody happens to be the first to respond, they're the ones who can ultimately go down the same similar chain of command in getting timely response up front. Allergy kits in general should be made available and accessible. This is our allergy kit on the right here at Beth Israel. It has things like a saline bag, pressure tubing, some antihistamines. Importantly, it has an EpiPen, which contains epinephrine at a concentration of 1 in 10,000. When people mostly reach for is the coat cart, and when they poke epinephrine out of the coat cart, you're talking about a concentration of 1 in 1,000. Now, according to my colleagues who are allergists, they say that at a concentration of 1 in 10,000, you're unlikely to get significant coronary vasoconstriction from that. But at a dose of 1 in 1,000, you might. And so starting with that EpiPen, it can be very helpful to have this if you otherwise don't have an allergy kit available to you, but it's not the same as a coat cart. Most of these really occur right away, within 30 minutes certainly, present with rash, skin erythema or redness, otherwise throat tightness, shortness of breath, flushing, or shock. This is not a CARPA reaction, but there is a low incidence of temporary back pain that's felt to be due to potentially complement deposition in the glomerular capillaries. And in general, both with CARPA reactions and with the back pain, we do recommend diluting the agents. What we get out of a vial of contrast is way more than we actually need. And there's increasing literature, and there's some good literature from the allergy world, that the rate of infusion, that peak dose concentration, is related to the incidence of a CARPA reaction. So if we dilute it and we give it slowly, we're less likely to see those reactions. So that's a key part of prevention here. But I also think it's important to recognize that historically, ultrasound contrast is amongst the safest of all contrast media. This is great work from Kevin Wei, comparing the rate of an anaphylactoid reaction of 1 in 15,000 to even iodinated contrast agents, where even with low osmolar agents, the rate of a life-threatening reaction is about 1 in 5,000. And you'll hear from a number of my colleagues who are radiologists that they really see way more reactions, certainly with iodinated contrast or gadolinium, than they do with ultrasound-enhancing agents. And so, while of course it's important, we should keep vigilance and preparedness for the reactions when they do occur, because they will occur. It's also important to contextualize that and understand that we do things all the time in medicine where we are taking some degree of risk for an expectation of benefit. And there's been a ton of data, a wealth of data published on this. The largest series is a study by my colleague Dr. Main here, 4.3 million patients from the premier data set in patients who received ultrasound enhancing agents, and compared to those who didn't get ultrasound enhancing agents, and accounting for their likelihood to receive those agents, they were actually less likely to die within 48 hours. So all of this certainly supports the robust safety of these agents. But I say before 2020 because something really changed in 2020, which is we had the great natural experiment of a pandemic, and everybody receiving or many people receiving a COVID-19 vaccine. And that's really sort of introduced another variable into the mix. And that's because PEG itself, which is in many of the agents, in 2 out of the 3 of the agents, and is really meant to be sort of a filler or help reduce the exposure of the agents to the immune system, and therefore allow it to persist longer in circulation and have less of a chance of a CARPA reaction. Some people themselves may actually be allergic to the PEG component. It's pretty rare, but you do get these history of people who have had multiple PEG exposures. So this is a particular case report by Cosby Stone, who's at Vanderbilt, is an allergist specializing in this area, and identified a patient of his who was a car mechanic and paint department manager who had multiple reactions in the past. So 3 years ago, had anaphylaxis to a steroid injection. Depot steroids have a lot of PEG in them. 8 months ago, had anaphylaxis to Miralax for a colonoscopy prep. Miralax is PEG. It's just simply a high molecular weight PEG. And then 1 month ago, got a PEGylated ultrasound enhancing agent and had anaphylaxis prior to the stress test. And they tested him, and sure enough, at a greater strengths, he had increase in wheals on his skin, so a positive skin prick test for the presence of a reaction to PEG. And this came out around the same time as people started getting the mRNA vaccines. It was the first time that an mRNA vaccine, of course, was used in a mass vaccination campaign. And the mRNA vaccine was also the first one to have PEG in it. And that's because, like the ultrasound enhancing agents, the mRNA vaccine was a lipid nanoparticle. And it contained a PEG at a molecular weight of about 2,000. And when people started having allergic reaction to these, there was a look back to see what was the allergy that could be causing this, and PEG was the only recognized allergen in the vaccine. But of course, it was known that PEG allergy was exceedingly rare, 1 in a million or so. That being said, the exposure to PEG in the population is massive. 24% of the population has IgGs to PEG. It's in skin creams, it's in cosmetics, all sorts of different things as a filler. And so the exposure overall to PEG has been increasing, and the reports of allergies to PEG also had been increasing during that time. And so that led to a potential question of, is anaphylaxis to the COVID-19 vaccine due to PEG? Well, it turns out That's not the case after sort of further research, but it got people thinking about this potential hypothesis and association. And there was a group at Penn that looked at adverse side effects, identified that 24% of those who had UEA reactions had vaccine adverse reactions versus 4% of controls. Again, mostly non-severe, but really hypothesis generating. So around the same time, the FDA MedWatch group went back and looked through potential sources of reactions in places that where reactions could be due to PEG, and of course identified that several UEAs do have PEG in them. And so they issued a safety report on presumed type 1 hypersensitivity due to PEG. This was based on 11 cases over 10 years. If you do the math, that's a rate of reaction of less than 1 per million doses. None of these were laboratory confirmed, so it's very hard to know what to do with that. PEG had been in contrast since before the safety data were published, the safety data I just showed you. And so maybe it explains some of the prior reactions, but it was hard to know how this was going to change management or change what we do. And so as a result, the ICUS and ASE came out with statements essentially saying business as usual, but there were new contraindications added to those who have known hypersensitivity to PEG or to bowel preps. And so a lot of people ask about the bowel preps, but not as many people ask about some of the other things like the depot steroids where there may be a lot of PEG. Complicating things is PEG is also structurally similar to that of polysorbates, another common compound, and there's cross-reactivity about 30%. So this is all making the waters a little bit muddy. And in the context of this, several centers did report on adverse reactions that they had. And this was a paper that came out in Chase evaluating 4 health systems, total 81 hospitals, where they concluded that the rate of severe reactions to contrast had increased, and in fact was related to, in particular, to Lumason, one of the brands in particular. There were a number of challenges for this study. They only included about 12 hospitals, about 15% that experienced the adverse effects. But the biggest thing, I think, when we look back on this is that the time period of use was different, that people, they compared contemporary use of Lumason during the COVID-19 pandemic to older use of Definity. And so is there a potential that something different happened within the context of the pandemic that really caused this safety to be changed? And we had, we do a large contrast volume site. We did have a case of somebody who had a stent in. They were doing well. They got contrast. They immediately had flushing and chest pain, a rash, hives, and ST elevations on the monitor. We took them back for a cath and found that they have a diffusely spasmed right coronary artery. They had no history of Prinzmann's or vasospastic angina. And so we really think that this is most likely Kunis syndrome, which is an allergic acute coronary syndrome. It can either be plaque rupture or vasospasm in response to histamine release from medications. And this may explain some of the more severe cases, although we know that this happens very, very infrequently, certainly less than 1 in 20,000 cases, if that. We did bring this patient back. It was a couple of years later. They in fact had negative skin prick testing for PEG, and so it really begs the question of did they have PEG antibodies that just waned, or is there some other mechanism at play here? But as we were sort of wrestling with this, we really recognized that there are lots of differences in practice in the way that people were administering contrast across the board. And certainly talking about contrast safety around the country, we find that people are giving large doses of contrast really quickly up front. And so and often without sort of a sufficient support for when a reaction does occur. So we really felt the need to be able to come up with some consensus around safe administration here to encourage use, because of course use should be encouraged, but to make sure that it's safe. So this is endorsed now by 14 different cardiac societies, including the American Society of Echo, the British Society of Echo, Canadian Society of Echo, and others. And it's a good read to. But I'll summarize the conclusions here. One is train your staff, prepare for this. So if you have ICUS materials, you have clinical application specialists, use those to be able to train your staff about what contrast is and what the reactions look like, how do you treat them accordingly. Teach through examples, have those staff repeat back those safety protocols. Assess and reassess their competency. Right now we're working to put together an annual competency where people watch a video about contrast safety and are able to test their knowledge about responding to this. And in particular, the local response is going to differ from place to place. The when, the how, and the who is so important. When we started a contrast use in a clinic in Lexington, we didn't start using it until we understood who was going to respond in the case of emergency, who was going to respond when that patient or that person was away, and what was the procedure for doing this. Have those allergy kits available in stock. If you do have any issues, track them. Retain the vial, report the event details, document the reaction. All the companies have pharmacovigilance groups. They want to know what those lot numbers are, but also it's important for you to know so that if that patient has another reaction, you could, or gets another echo, you've documented accordingly. And then I think an underappreciated thing is debriefing about ways to improve. I think as a lab, this can be jarring, particularly for people who are not used to dealing with reactions or rapid response situations. And this may be their first time experiencing that. It really is good to sort of settle in a group what went well, what didn't go well, but also how do we support each other accordingly. Our lab, we keep a flashcard on all the carts, but also in all the rooms where we inject that says, essentially, if there was a reaction, you call the fellow on call, and the fellows are taught that this is like a STEMI. They have to drop everything and run to go respond to support the sonographer accordingly. And that's worked really well. Now, the secondary question was, is contrast still safe? You know, we really wanted to do, can we do a larger study and look at this? And we did do this in a wonderful editorial by Matthew Cefaletto, but I encourage you to read through this. We looked at 21 million patients during that 2018 to 22 period who had transthoracic or stress echocardiography, looked at those who got contrast versus those who didn't, and matched them on likelihood of getting contrast. And that's important because we realize people use this in different settings. People use Optison more frequently as an outpatient, people use Lumason and Definity more frequently in inpatient ED setting. And so there's some differences across these, and if you account for those differences in the match cohort here on the right, you can see that really, in fact, accounting for those differences and, importantly, accounting for likelihood of receipt of the COVID-19 vaccine, the death rates were in fact very low. Anaphylaxis, MI, VT, cardiac arrest, all very low and similar between agents and between people who got contrast and didn't get contrast. And in fact, if you look at this, we reproduced the results really from that seminal study by Dr. Main and colleagues looking at showing that there was a protective benefit within 48 hours in risk of death, regardless of the agent that you looked at. And that was true across the year of study too, both agent and across a year. That there really wasn't a significant sort of inflection, rise and fall here. This is, of course, all other things being equal, accounting for likelihood of having a reaction. So how do we reconcile that with the prior reports? And I think, you know, there's a couple of things that we want to consider here. One is COVID-19 was introduced a great deal of perturbation. And if you just look at the rate of reported adverse events to the FDA, this is from data from the FDA Affairs data set that's in press right now from our group, looking at rate of reactions, and you can see there was a rise and a fall right around the time of COVID, and certainly mirrored that with the reports that were specific for contrast ultrasound. And if you just look at that, you can see that since 2020, the background rate of reporting has been falling. And so therefore, if you take a ratio of the number of serious adverse events to the total reported events, that total is going to be increasingly smaller, and therefore your ratio is going to get increasingly larger, and that's what we see. And so about a third of the increased use or increased risk, so to speak, for contrast during that period was really due to changes in reporting in the denominator. But we do see still a rise and fall in the rate of events, and that particularly for the pegylated agents, Lumason and Definity, equal for those two agents, and then now since falling since the peak of COVID. But again, important to contextualize this. So if you look at gadolinium and nitrogen contrast, their risks actually fell during COVID, but still they remained at higher risk. There were higher risks associated with gadolinium and nitrogen contrast compared to ultrasound contrast, despite that relative increase during the pandemic period. And as a positive control, we found that another pegylated agent also had a similar kind of rise and fall. So we think this potential change was due to PEG, but it is a relatively small by comparison. Overall, the safety of these agents is maintained. And what can you do about it? Well, one thing, we've helped develop a screening tool here that you can use to be able to identify the rare bird of the person who has true IgE-mediated antibody reactions to PEG. And this identifies people who have multiple anaphylactic reactions accordingly. It did have a very high sensitivity and specificity in people with known PEG allergy and in a Vanderbilt allergy clinic, but we need larger studies to really understand the impact of using this on care. There are a number of things to consider. This is going to catch the people who have the true 1 in a million allergy to PEG, that's an adaptive immunity type 1 hypersensitivity response. What I think we're seeing more frequently of is that probably around 9 to 10% of the population has persistent IgM and IgG antibodies to PEG, meaning they've been exposed at some point in time in the past. And we know that people who have IgGs or IgMs to PEG, actually those antibodies may potentiate CARPA reactions. They may have a higher risk than the general population or people who don't have those antibodies of having a CARPA reaction. But which ones of those people are going to develop CARPA reactions and which ones don't is very hard to sort out. And so therefore, we need to do what we can to make it safer on our patients. So slow rate of injection, dilute the agents, to the extent that possible. We can try to minimize the amount of PEG that we're using these agents or modify it, and I'll talk about that in a second. And then really being prepared when these events do occur to make sure that we're responding appropriately. Now, how do we make lipid nanoparticles safer? This has been looked at in a couple of different ways. Well, you could increase the size of it, but that has issues because the bubbles have to be small enough to go through the pulmonary capillaries, and so that's a safety issue. You could change the charge of it. So it turns out cationic lipid nanoparticles are immunogenic, so you can make it non-charged, and that's being worked on in some settings. You could modify the PEG. You could shorten it, make her lower the density. We think that the PEG is like a floppy noodle. The larger the chain, the more likely it is it's going to bend back on itself and reveal binding spot. If it's short, it's unlikely to happen. But the larger the PEG, the longer the circulating time of the agent too. So there's a trade-off. You could have branch chains of the PEG, or you could remove the PEG altogether. You could substitute something like polysarcosine, which has a longer in vivo circulation times, fewer systemic reactions, and potentially lower CARPA reactions. But all this takes time. So while that's being worked on in the background and really the safety study, the core safety studies are being looked at, we have to recognize that we need to be prepared for these circumstances. But what it doesn't mean is we should not, we certainly shouldn't avoid the use of contrast. And I keep this because the diagnostic error rate is, and the risk, we take risk all the time in medicine. It's a question of risk and benefit, and lowering the risk and maximizing the benefit. The risk of not using contrast is higher than the risk of using it. And this is from the IOM. Postmortem exam research spanning decades has shown that diagnostic errors contribute to about 10% of all patient deaths. There's about a third of patients experience misdiagnosis in their lifetime, accounts for about $100 billion in costs. And so this is an extreme and important issue. And getting the right diagnosis at the right time, it overweighs the minor increase potentially in risk that you may take during a transient time period. So take-home points here, just to summarize, PEG is associated with a large increase in risk for a very, very small number of people, and a very small increased risk in risk for a larger number of people. Despite that, however, ultrasound contrast remains amongst the safest of all contrast agents, and that risk is waning. Proactive screening, standardizing safe laboratory practice, and evaluation alternatives to PEG are future directions. But in all of this, the risk of non-use needs to be considered, and we need to use what we have at our disposal to make the right decision up front. Thank you very much.
Thank you so much, Dr. Strom. Tremendous talk. It's now my pleasure to introduce our next speaker, Dirk Clevert, MD, Professor of Radiology and Section Chief, Interdisciplinary Ultrasound Center, Department of Radiology, University of Munich, Grossharden Campus, Munich, Germany. Dr. Clevert, thanks so much for joining us.
Yeah, Matt, thanks for the friendly introduction. So I hope everybody could see my presentation and my audio is fine. So this will be my disclosure, but of course this will have no influence on my talk. So in my talk, I will give you some clinical cases. Then we will speak about, understand the safety profile of contrast, recognize the contraindication, apply safety scanning technique. And of course, we have to speak about how to manage adverse reaction. Part of this topic is already covered by Jordi, but I think an overlay is still good because these are rare stuff. So when we speak about contrast and ultrasound, the major organ we are using is for liver. We start with a grayscale. We see this beautiful liver lesion with a diameter roughly about 2 centimeters. Of course, we look for color Doppler and microflow imaging, and we see this lesion doesn't have major vessels inside. But could we now give a proper diagnosis? What is the name of this lesion? I think we could flip a coin to make a decision what will be the final name. We need contrast to give this lesion a name. So we inject contrast. We see very nice perinodal enhancement in the arterial phase. You see these nodules are slowly growing. And of course, we record this and we see still growing and growing. Then we will repeat the examination and go to the high super resolution technique. Maybe it's improvement. You see time of arrival is coded in red. On the other side, you see very, very tiny feeding vessel. You see these beautiful nodules in the lesion which show an uptake. And of course, we are going in the next step to the portovenous phase. You're still growing. And in the late phase, that's more than 3.5 minutes. The lesion, most of the lesion is completely coated with contrast. This means it is a typical behavior of a hemangioma. There will be no need for treatment, no need for biopsy. But my next case look very similar. And before I show you the case, I would like to show you also the advantage of the resolution, where you see the tiny feeding vessel and the perinodal enhancement. As I told you, my next case look very similar. Of course, this lesion is a little bit bigger in comparison, but it's hypogenic. Of course, it will be boring if I will show you 2 hemangiomas at the same time. Of course, it must be something else. So in the next step, I will provide you with the color Doppler and microflow vascularization. Even if you look at these options, you see some peripheral vessels, but no major vessels inside. So it seems to be very similar for the vascularization by using this technique in comparison to the previous case I've shown you. And of course, we go to the contrast and you see there's a complete different behavior. This lesion show a very, very strong uptake. Most of the lesions show a strong uptake. And if I go to the portovenous phase, you see immediately there will be a washout. If we summarize this information, we know exactly this must be a liver met. And if you have the time and look for super resolution, you see very nice. This is not a perinodal enhancement. This means it will be not a hemangioma. And the final diagnosis of this tumor was a neuroendocrine tumor. This means the patient has got a neuroendocrine tumor, and this was a mets from this tumor. So this means a complete different treatment pathway for this patient in comparison to the previous patient. I think this is a very interesting case because this is a young pregnant woman, 8 weeks of pregnancy. She suffers from abdomen pain. So we have done an MRI without contrast. And in the final diagnosis in the MRI, we describe either it must be a necrotic tumor, it could be an abscess, or an hydatid cyst. And of course, these are 3 different diagnoses which have got a different pathway of treatment. Now, it is difficult to make a decision, or we go to the contrast. We see this lesion in the grayscale. We see there is no vascularization inside. And of course, the next step, we will go to the contrast. You see this lesion show a very, very strong rim enhancement. There is no uptake inside. So we know immediately this is not a tumor is just an abscess. And of course, the treatment will be place a drainage inside in comparison to surgery. And how good is contrast now in pregnancy? There's a couple of papers which look for the outcome. We have published a couple of cases, and also Stephanie Wilson just recently published a paper regarding pregnancy and contrast ultrasound. And in all our study, we could say it was, or it is, very safe. It could use for obstetric and non-obstetric conditions during pregnancy. And of course, it will be improved the diagnosis and also the pathway of treatment. Just last year, there was a big multi-center review. So in this review, the author looks for more than 13 different articles regarding pregnancy and contrast ultrasound. In this study, there was included more than 250 women, and they found that there was no clinically significant adverse events and no effects during pregnancy. This means it seems to be very, very safe. But of course, keep in mind, it's only a limited number of patients because pregnancy and contrast is more rare case. What is much more used is contrast and ultrasound in kidney lesion. This patient was sent to us with an unclear CT lesion detected by a CT. So is it now a hydrated cyst? Is it a hemorrhage cyst? Is it a solid tumor? So we see a very strong reflected wall. We could not see vascularization in this lesion. And if we go to the contrast, you see a nice uptake of the kidney, but you see the complete lesion is filled with contrast. This means also in the later phase, you see a slightly wash out of this lesion in comparison to the rest of the kidney. And if we summarize the information, also you see there is an uptake inside. This means we could exclude all kind of cysts. We could exclude all kind of abscess. Unfortunately, this was also renal cell cancer, which have to be treated. Another case also here, this was detected by CT. In CT, they describe a hemorrhage cyst. And of course, this is a big tumor. This has got a diameter roughly about 4 centimeters. But even by color Doppler, we was not able to detect flow. If I will tell you as an expert for ultrasound, is this a typical behavior of the typical image for a hemorrhage cyst? I think most of you will say, no, it's not typical. So it must be something else. And now we go to the contrast. You see nice contrast uptake of the kidney, but you see tiny bubbles show up in this lesion. And over time, slowly, but there's still an uptake. And in the later phase, this lesion has gotten wash out. Unfortunately, this patient suffers from a papillary cancer, which is very typical that they have got a very low uptake of contrast. So in of course case, this must be treated. What about vascular diseases? Vascular will be my major topic. Of course, patients with a AAA have to monitor when will be the right time to receive an aortic stent graft. If I look at this patient, which is only have got a AAA not treated, we see a huge aneurysm, abdominal aortic aneurysm with a diameter roughly about 5.5 centimeters. By using the fusion tool where I match the CT image and the ultrasound image, the previous CT and the ultrasound, I see the aneurysm is stable, but still there is a big aneurysm. And of course, if I look at the technique, you see the overlay match perfectly. You see contrast stay inside. But now it will be also the time to think that this patient probably need an aortic stent graft. And of course, if you have got an aortic stent graft, you have to think about side effects which could happen after placement of an aortic stent graft. The most common side effect or complication will be that the patient suffers from an endoleak. So we see very nice aortic stent graft inside of the aorta. We see some hypergenic structure inside. And by looking at cadaver, it seems to be a flow. So we know there's an endoleak. But now we have to give the name of the leak. Is it a type 1, type 2, or type 3? So where's the feeding vessel? Where's the entrance? Where's the exit? By looking for contrast, you see a nice perfusion of the stent graft, and you see also immediately this endoleak showing contrast uptake. And I've optimized the scanning angle, and now I see there's a communication. Is the feeding vessel the lumbar artery or the IMA? And of course, this has got an influence because the treatment of the lumbar artery in comparison to the IMA is completely different. So I find a solution. I just burst the bubbles. I will show you in a minute. And you see now the pathway. So you see it's bursting. And of course, you see the entrance of the bubble is the lumbar artery and the exit is the IMA. So we can now say to the doctor how to treat this complication. When we speak about small parts, also often we use contrast. This is a nodule in the thyroid. Typical for this nodule is that it's got a very strong rim color enhancement, also some central vessels. This is typical for adenoma. And what about the perfusion? So also here we see a nice perfusion of this lesion, strong uptake, much faster in comparison to surrounding tissue, and slightly wash out, but this was the adenoma, also no need for treatment. Another small part, of course, will be this tumor. It's a lytic cell tumor. This means it's a benign testicular lesion. And we look at this lesion. This lesion has got a diameter roughly about 5 millimeter. By looking at color Doppler and microflow imaging scene, we see some peripheral vessels, but no major vessels inside. By looking for contrast, we see a very nice homogeneous uptake of this lesion. We don't see chaotic vessel pattern inside. And over time, you see how nice this lesion filled. By looking at the super resolution technique, we confirm the information we already have seen. So no major feeding vessels inside, no chaotic vessel pattern. And the super resolution, you see the complete enhancement of the tumor. And you also see on the other side the arrival time, which is very homogeneous in comparison to other area of the testis. This means it's a lytic cell tumor, also no need for treatment, it's a benign tumor. Now the question is how to do the pre-examination checklist. First of all, to minimize the risk is very helpful if you ask the patient, did you have any side effects in your last examination? What about your cardiac status? Is it fine or did you have a problem with the heart? Of course, we have to explain all the side effects, what could happen to our patient, and get an informed consent of this. And finally, we need a proper IV access in order to place the contrast enhanced ultrasound, the bubbles inside, but also if something happens, we have to have an IV access to inject the drugs. So when I look at this paper, where are the guidelines and recommendation for liver and non-hepatic liver? If I summarize all this information from these two major papers, they can say generally it's a very, very safe contrast agent. It has no influence on kidney and it has no influence on thyroid. There is no risk of NFS like we have got it in the MRI. Therefore, it's safe in renal insufficiency and there is no need to have a lab function before we start the examination. So we can go on and we have got a very safe examination. What are the risks having adverse reaction? So anaphylactic reaction could happen in 1 in 7,000 cases. Serious reaction happens in 1 in 10,000 cases. And if we look for the total number of Lumason, this will be close to 2.5 million examination. Unfortunately, also 14 patients died, but in comparison to other agents, it's a very, very safe agent. On the other side, I show you the risk if you use CT or MRI contrast. You see the risk for CT is nearly 10 times higher in comparison to contrast and ultrasound. And the risk for MRI is similar like ultrasound contrast agent. So contrast ultrasound has a low serial reaction rate, lower than CT and comparable to MRI contrast agent. So if we would like to conclude the guidelines, we say contrast ultrasound is one of the safest contrast agents in imaging modalities. Serial reactions are extremely rare. It is safe also in renal failure, pediatrics, and pregnancy. During our last bubble conference, which I could recommend very, and it will happen also in the beginning of October this year, we had got an expert roundtable and we are speaking about the safety of contrast ultrasound. I just focusing on my part, this will be radiology. So in the literature, there are more than 600,000 cases. For minor events, it was very low, and for serious events, it's even much more lower. And in radiology, no death is reported. I also would like to share with you the information of one of the biggest centers in Canada from Sheffield Wilson, Calgary. She have done more than 25,000 patients. And she told there is no significant adverse events. My personal experience with less number, it's only 11,000 examination, we had got 60 mild events and 1 severe event. What are the safety preparation? So all center have to be a screening question. All patients have to give an informed consent from the patient. Make sure that the IV access is proper and you are trained in BLSA training and you have got a crash card. You never know when it happens, but you must be prepared, even if it's sometimes really rare. What about the risk of other modalities? Of course, we don't have any risk like radiation, so no radiation risk in contrast ultrasound, and also an MRI radiation dose. The renal risk doesn't exist by contrast ultrasound. It's moderated in CT, and it's also a slight risk in the MRI. The risk for side effects like allergic risk is very low. It's moderated in CT and similar like in MRI. But we can repeat the examination as often as we like. In MRI and CT, they are limited due to the dose. What are the symptoms? We could divide the side effects in mild, moderate, and severe. And according to the stage, we have different symptoms. And of course, we have to think about what will be the management, which shown you clearly on the table. The best will be immediately stop the injection. Think about the airways and think about, is there any need now to inject drugs or not? Often we have got clear rules. What will be the next pathway which you have to give a call or what? So symptoms, stop injection if it's a mild or moderated. If it's more severe, we have to think about excess of ABC and classifying the side effect. This means if it's a mild or moderated, we just monitor. If oxygen needed, we give him. And sometimes we give antihistaminica and we observe the patient at least 30 minutes. If the patient is stable, we have to think about whether the patient should stay still in hospital or could go home. If it's severe reaction, we have to give an emergency call. We have to think about the airway support. We give him, of course, drugs and oxygen, and the patient will be transferred to the ICU unit. So the final conclusion from our roundtable from Chicago last year is that CEUS is one of the most safest contrast modality. Serious reactions are very rare. Of course, there is still a benefit because if we do nothing, there might be a higher risk for this patient. But we also should integrate training for our residents in the sonograph skill and also in cardiology practice. The keynote message is, it is often more dangerous to do nothing instead of to using contrast. So the complete summary is, we are speaking about an excellent safety profile The adverse events are very rare, no renal risk, no radiation dose, and of course it should be the first line contrast imaging if you have a good indication like liver or non-hepatic examination. With my last slide, I would like to thank you for attention. You can scan the QR code to get access to more cases. And of course, I would like to welcome you to the next international course in Munich. Thanks again for your attention.
Thank you so much, Dr. Cleavert. Great talk. It's now my privilege to introduce Casa Dargay, MD, PhD, FAIUM, FSAR, FSRU, Radiologist in Chief, William L. Van Allen Endowed Chair, Department of Radiology, Children's Hospital of Philadelphia, Professor of Radiology and Surgery, Perelman School of Medicine, University of Pennsylvania, Philadelphia. Dr. Dargay.
Good afternoon, everyone. It's really indeed a great pleasure and honor to be part of this panel to present on the safety of contrast ultrasound. And I'm very happy to complement the presentations with the experience of contrast-enhanced ultrasound in children. At the Children's Hospital of Philadelphia, we're very fortunate. We have the Center for Pediatric Contrast Enhanced Ultrasound, led by Dr. Susan Back and Trudy Morgan, that has really embraced contrast ultrasound in children and advanced the modality in our department so that we have a large experience pool. We have a dedicated colleague, Dr. Ekaterini Natalia, who is responsible to monitor the safety and has done great work regarding that. And I thank her for a lot of the data that is being presented in this talk. I have no relevant disclosure related to this presentation. The objective of my presentation is to review the literature on the safety of pediatric intravenous contrast enhanced ultrasound and intravesical contrast enhanced voiding urosonography, and also share with you the CHOP experience on safety of pediatric contrast ultrasound. Just as a general information, the ultrasound contrast agents that have been approved in pediatrics are as follows. In 2016, Lumason, which is known outside the US as Sonoview, was approved in the US for the intravenous use for liver after 2016 for liver and cardiac imaging, and also for intravesical administration for vesicourethral reflux evaluation. In 2017 and 18, the same contrast agent was approved in Europe and China for pediatric use. It's only approved in these regions for intravesical application. Definity, another contrast agent, became approved in 2024 for cardiac application in children. It was available in the US for use in adults. And similarly, in 2025, Optizone got approved also for cardiac examination in children. And this was also available for use in adults in the USA. So let me start with the intravenous administration of ultrasound contrast agent in children. There is a very detailed compendium dedicated to contrast ultrasound in children that was published in 2021, led by our group, the Center for Pediatric Contrast Ultrasound. In that compendium, there is a detailed presentation about the safety of contrast ultrasound in children, and many studies were included. They also covered all the ultrasound contrast agents that have been used in children. In this data that I'm showing you, this has been updated to reflect that numbers. So currently, there are about 79 publications that deal with pediatric population, evaluating the safety of ultrasound contrast agent in the intravenous administration. So as you can see, there are over 5,000 children included in the studies with over almost 5,500 IV injections. Serious adverse events that have been described, the anaphylactoid or allergic reactions, the severe ones, have been reported also in children. This have been primarily reported with Sonoview or Lumason, and in this group of patients that I presented you, there were 10 cases. There have been no such reports of adverse events with the other two contrast agents, but as you can see, there are only very few studies with the other contrast agents. So the rate of adverse events just based on this number is 0.18%. The 10 serious adverse events that have been described in the literature and detailed in this table, both comprising in female and male patients of various age groups, 7 were anaphylactic or hypersensitivity reactions, and 3 involved hypotension. They were acute or immediately or within 3 minutes after injection, and all required resuscitation, but there were no fatalities. When we talk about non-serious adverse events for the intravenous application in children, the numbers are higher. And as you can see, all 3 different contrast agents exhibit non-serious adverse events, but even then at a very low rate of 1.02%. And what are these non-serious adverse events? When we look at it for the contrast agent Lumason or Sonoview, which has been described in 0.65% of cases, the majority are skin reactions. Yeah. And then furthermore, you can have tachycardia or hypotension, hyperventilation, and GI symptoms that consist of taste alteration primarily, or other symptoms like stupor-like reactions. But all others are far and few, and only single cases have been described. Similarly, for Optizone and Definity, there were 14 and 15 non-serious adverse events, respectively, and they consisted of primarily for Optizone with taste alteration was the main finding. With Definity, chest pain and fatigue have been described. The others are primarily just fewer cases of non-serious adverse events. When we compare with other imaging modalities regarding particularly the serious adverse events, you can see with contrast-enhanced ultrasound the rate of 0.18%. In this, from this literature quoted for CT, similar rate, slightly lower rate with the gadolinium quoting this rate, and they were almost double number of exams in the CT and MRI. But all over, you can see the comparable results or even low rate of serious adverse events related. I cannot emphasize what my colleagues already described, the need to be alert that rarely serious adverse events can occur with the intravenous administration, and be prepared. Having a code chart in the ultrasound department or near the ultrasound area is very important, even though the happenings, as you've seen from all the numbers and also from my colleagues, are very few. When we come to the intravesical administration of contrast ultrasound, there are many more cases that have evaluated the safety, and primarily those involve Sonoview, Lumason, few cases with Optizone, none with Definity, but a significant number of cases have been used. But as you can see, no serious adverse events have been described with the intravesical administration of the ultrasound contrast agent for detection of vesicoureteral reflux. There have been few cases of non-serious adverse events. Even you see from 13,000, there were 37 that were reported. And this is at a rate of 0.29% of non-serious adverse events. And they are really subacute. And from those that are presented, they were self-limited, no medical intervention. And one had a urinary tract infection and was hospitalized for that. But look at these non-serious adverse event, how mostly it's dysuria, and then urinary retention, abdominal pain, or urinary infection. The others are single cases. And all these are comparable if you do voiding cystourethropy or nuclear studies for reflux. And all three have something in common. They place a catheter in the bladder to administer the contrast agents. And these have been described with symptoms related to placing a catheter in the bladder. And these are less likely associated with the contrast agent, but most likely a consequence of having a catheter through the urethra into the bladder. What is our experience? We've been doing contrast-enhanced ultrasound since 2013. That's almost now 15 years or more. And we have done quite a few, over 3,000 exams in children. And to remember, this number is significantly high when you think about children. This is not an adult practice, so 3,000 exam. And this especially has increased since 2016, since Lumason was approved in the United States. We have over 1,500 cases in intravenous, and over these past years, we have seen 2 serious adverse events with over 1,000 cases of intravesical administration. We have not seen any other cases. In our department, contrast-enhanced ultrasound is used for widespread indications. So we have a significant number of interventional contrast-enhanced ultrasound, both intracavitary, intravenous, but also we have really advanced the intralymphatic application of contrast-enhanced ultrasound for various indications to localize the lymph nodes for MR lymphangiography, to detect the thoracic duct for patency. All the contrast ultrasound is used. These are other applications, but we didn't have serious adverse events with those, only with the intravenous one. So these 2 cases were a 3 and a 4-year-old girl and boy. The reactions were recognized immediately. An emergency protocol was followed. Both recovered. They did not need admission. But these are 2 cases that we have seen since using contrast ultrasound in our department for over a decade. In another very interesting study that we did jointly with our colleagues at Johns Hopkins, these colleagues led by Dr. Misun Huang looked at critically ill children, all children who are in the ICUs, in the neonatal intensive care unit, in the pediatric intensive care or pediatric cardiac intensive care unit, who had received contrast agent intravenously for various indications. The vital signs were looked at 30 minutes prior, during, and after all the exam, and also up to 24 hours if available, and other metrics followed, and they did not detect any clinically significant adverse events, even in children in the ICU with complex medical conditions. So in conclusion, ultrasound contrast agents in children are really well tolerated and really demonstrate high safety profile. There are serious adverse events with the IV use, very low, But most importantly is to know that one needs to be prepared for this very rare occurrence. And I've shown you over a decade, we have 2 cases, but still we have a code card in our ultrasound unit. There are no serious adverse events with the intravesical applications. And we do have to remember and emphasize that the use of ultrasound contrast agent in children, especially with those with renal insufficiency, transplant patients, can be easily used. It's non-nephrotoxic. And remember, the examination contrast ultrasound with the use of an ultrasound machine is easily accessible. Parents can be near the children. Children can be examined in different ways. It's portable. The examination is quick. It's easier to get an appointment to be able to do that. And most importantly, we really have to appreciate in pediatrics, I think this is the point that really stands out compared to adults, is by doing that, we may be able to avoid an examination that requires sedation or anesthesia or radiation. And these are very important workflow and patient safety issues that we are dealing with. And with the addition of contrast ultrasound, we can avoid all this. So the benefits of ultrasound contrast agents in children really outweigh any risk concerns. Thank you very much for your attention, and I'm ready for any questions. Thank you.
Thank you so much, Dr. Dargay. Tremendous talk. I am going to now hand it over to our moderator, Dr. Main.
All right. Well, thanks, Matt. And encourage folks to continue entering questions in the Q&A box. We have a few of those. And first one I'd like to start with a question on, should we now be using non-PEG agents? I think, Joy, this is a good question for you to kind of raise that issue. There have been some different adverse event rates according to the contrast agent amongst the 3 that are commercially available.
Yeah, I think it's really not a substantial enough of a difference between the different agents to really say we should wholesale be using one versus the other. I think we have to see them as a class, as a safe class, but also understand that PEG is an issue in a small proportion of patients. We don't know what that proportion or how to identify those patients ahead of time. So I think what we probably in the interim will sort of end up doing is stressing the issues of safety. So giving it slower, giving them it diluted, starting with small boluses or infusion and increasing based on the image quality is, I think, going to have a better response. Is it wrong to have non-pegylated? No, I don't think so. But I think there's a lot of other reasons why people use some of the pegylated agents versus some of the non-pegylated agents, and all those things have to be considered when making a decision to use one agent or the other. The PEG is really not a substantial enough of an increased risk that it makes a huge difference here.
Just a follow up to that, in your very large paper, very large sample size paper that you published just recently, one of the pegylated agents did have a significantly higher reaction rate than the other. Do you think that's just noise? You think that's real? And if so, what accounts for that?
It's really hard to interpret the FDA reported data because there's no quality assurance in terms of who ends up submitting things into the FDA data set. And then that's a recognized limitation of this. None of this is vetted. And so are these truly reactions? I think can be hard to know. It's labeled as serious. Is it serious? So I think that's always a big challenge, and when people are sort of attuned to things, particularly if there's things going on in the background, the release of publication that may sort of tip people off to maybe a risk there, then it becomes a sort of a self-fulfilling prophecy where people may report more. So I think it's not at all straightforward. I think if you look at a large unselected group like we did in our claim study, accounting for all of the other characteristics that may lead one to get one agent versus another, that doesn't seem to be a difference. And that's and not only that, but it's extremely safe and safer to use the agent than not to use the agent.
Another question about mode of administration and the propensity for adverse reactions. I'd like to just go around and ask each of the panelists, what mode of administration do you usually use? Is it a continuous infusion? bolus injection. And the questioner also noted that they've noted that faster injections cause more back pain, which I think we would all agree is actually true. So why don't you go ahead, Dirk? How do you inject contrast? What mode do you use, and what would you recommend?
I do a manual bolus injection. And of course, we debate whether if we have a slower bolus injection that might be helpful. The problem is this have also an influence on the kinetic of the arrival in the liver diagnosis. So I think we should not change the bolus speed, because otherwise we maybe get problems for the different enhancement pattern. So yeah, that's our problem. We still have to handle this, but we could not change the speed of the bolus. But if a symptom happens, to my personal experience, it happens immediately. So the patient tells you immediately, oh, I feel a bit dizzy, something is wrong. And what I also would like to recommend, if a patient already received, for example, Lumason once, this doesn't exclude if the patient comes for a second time that there will be no side effects. I had also one patient, and he told me, oh, I have got contrast in the past and there were no problem, so I'm safe. I said, yeah, I hope so, it's safe. But unfortunately, this patient showed a side effect. So keep in mind that if a patient already received Lumason once and everything works fine, the second time it could be changing.
Yeah, idiosyncratic reactions. That's exactly right. Casa, same question.
Yeah, so for the pediatric intravenous application, for the routine clinical use, we do use bolus at the same reason Dr. Clevert just mentioned. But we do have the saline flash. After that, we flash the tube with normal saline for a push. But we are not using an infusion. For the intravesical one, we dilute the contrast in normal saline and administer it as an infusion into the bladder. So that's a different way of application. However, I can share with you, in years past, when we started this method, we used to directly inject also in the bladder. We didn't see any additional adverse events with that, except the fact that it was too concentrated in the bladder to visualize the retrovesical space with a direct injection. So we resorted to doing more with the infusion of diluted contrast for intravesical application.
Yeah, it's interesting to see how this differs across specialties here, because of course, the rate being a critical importance to the radiologic applications here. In cardiology, certainly there's a mix of bolus. We mostly do bolus injections of a diluted agent, though. So we'll dilute sort of 1-to-1. We'll take 5 mLs of agent and dilute an additional 5 cc's of saline, and then give about a half a cc to 1 cc slowly. And I think give it very slowly. And the key also is that chaser, so to speak, giving that very, very slowly too. I think we give that over at least 20 to 30 seconds, and oftentimes even more slowly if we're giving it through a central line. So it functionally becomes like an infusion. For stress echoes, we'll do an infusion. So if we do dobutamine stress or otherwise, we'll do an infusion for that, and that can be helpful. We haven't had any reactions to the infusions. They probably do fewer infusions than we do bolus injections, but again, it sort of gets back to this idea of sort of the carpal reaction in general is a little bit dependent on the speed and rate and peak dose concentration of the reaction, so of the injection. So to the extent that it is feasible and it's not going to interfere with your interpretation of the results, then it makes sense to sort of limit the amount that you give and give it over a longer period of time.
Great. Pop, a question for you from the audience. Do you have a policy or a consent form for pediatrics?
Yes.
To receive contrast? Tell us a little bit about that.
Since the approval of the ultrasound contrast agents for both intravenous and intravesical use in the US, we don't have the consent for clinical use. on-label or off-label use. It's routinely applied. We inform the patients and families that we use ultrasound contrast agent and explain the procedure, explain that we are not expecting adverse events, less likely, and the way we present. They also get a screening form for contrast agent like we do it for MR or CT, but not specific consent form. We do consent if it's a specific prospective research that involve contrast ultrasound. That's different.
But what about the others in terms of consent? You asked for written consent or just verbal consent? Dirk?
Verbal consent, and sorry, did you say Dirk or Jordy?
Go ahead, Jordy, then we'll get Dirk started.
Jordy.
Sorry, you and I look very similar, right? So, no, I think it's verbal consent has been the sort of standard of care, at least where we are, and what constitutes an appropriate level of verbal consent and what goes into the language around that, I think is always a little tricky because you don't want to sort of tell people a whole litany of risks and get them sort of in their head about anxious about it, but at the same time you know that there's potential benefit to making sure that they're well informed. So curious what others do as well. So I apologize for interrupting, Turk.
We do a written consent, and of course we give the paper to the patient when the patient arrives, so the patient have enough time to read this paper, then they have to sign. We explain it additionally. And the first sentence for every report I write, I give the patient give written and verbal consent for the examination. That's my first sentence for every examination.
Good. We do have a question here about CME for the webinar. Matt will cover that kind of in his closing remarks in just a few minutes. We'll hold off on that. There was another question for Jeremy. You mentioned a competency for dealing with contrast reactions, and people wonder if that's available to share.
Yeah, I'd encourage people to, if you're interested in learning more about that, to get in touch with Northwest Imaging Forums, and certainly we can connect after the fact, and I'm happy to send what we have in terms of documentation at our site. But generally sort of rule goes through the sort of types of reactions, what our individual local protocol is for responding to those. And that's a useful thing that we've sort of built on top of our existing competency system.
You all talked a little bit about screening for PEG allergies, the fact that PEG is ubiquitous, everybody's exposed to it, everybody almost is exposed to it with the COVID vaccines as well. So if we go to the trouble of screening for PEG allergy, how is that actionable? Would you change the type of contrast administered? And question, I guess, first for Jordan, you raised the issue, but Dirk and Pansa as well.
Yeah, I would just caution people. I don't think we're ready yet for screening, for mass screening. We really, this is a pilot study that we've done that we see we can at least theoretically identify people who have true PEG allergy. But given those people are very, very rare with true IgE-mediated PEG allergy, it's 1 in a million. My concern is that we could have more false positives and restrict access to contrast in those individuals who don't truly have a PEG allergy. So I think more work needs to be done to show the use of this in practice and what ultimately happens to care. That being said, I think there may be solutions if you have a non-pegylated agent on site that you would want to use with that person, or just to be aware and flagging that this individual may have a PEG allergy, because oftentimes they've been bounced around to multiple different clinics because they've had allergies to this, that, or the other thing, and it's because a lot of things have PEG in them. And so, chemotherapeutic medications have phosphate sando, sort of effervescent phosphorus has a lot of PEG in it. There's many depot steroids, Miralax. So certainly, ultrasound contrast is not unique there, and certainly if you have somebody who has multiple allergies, I would maybe ask them a bit further about that, and that may be an insight into something larger going on. But again, still so infrequent that even still most of those individuals are most likely not to have true PEG allergy.
I mean, I just want to share that what Jordan explained is really applies to pediatrics the same. And I mean, when we rarely see the adverse events, we also go into details of asking all these things, but I've never encountered where that was the case. So, I mean, it's good to know, but I don't think we can avoid it, and we just need to be prepared. And as I mentioned, with a code card and be ready that something may happen. And that's more practical, I think.
I probably confirm your sentence. So you have to be prepared that something could happen, and probably most of the patient didn't know it.
Mhm. Absolutely.
Yeah, I would just sort of emphasize, just to, if you don't mind, everything that, we might work in different applications in different settings with different people, but one thing that is remarkably consistent across the group is the messaging around this, which is that contrast is overwhelmingly safe, and it still is overwhelmingly safe, and that there are potential harms to non-use that we need to consider accordingly. So I think as we need to be prepared. We all need to be prepared. We always need to be prepared as a laboratory for these events when they do, if and when they do happen. But it shouldn't ever restrict us from using it in an appropriate circumstance where we feel that we would extract diagnostic value from it.
Absolutely. And that kind of goes along with another question in the chat. Why do you get consent? CPNMR don't get consent for contrast. And that's true. We have, I think, historically, certainly over the past 20 years or so, since the initial FDA warning, has been held to a little bit higher bar than some of the other modalities, given the fact that we have such a low incidence of these serious adverse reactions. Begs the question, why do we need to do this? I think we're trying to be, as safe and as responsible as possible, but it is a safer modality than those in general. Yeah. Another question. Jordy, you had mentioned that in some of the large studies that have been conducted, there actually seems to be higher survival rates or lower mortality in patients who've received a contrast agent. And of course, people are going to wonder a little bit about that. There doesn't appear to be any therapeutic benefit of receiving a contrast agent, so it must be related to better and earlier diagnosis and treatment, I would suspect. But thoughts from you and the other speakers on why that would be true, because that's come through in several studies now.
Yeah, it's a really interesting and important point. I mean, I think there's a number of confounding factors here. So one is, the places that are administering contrast may also have differences in the kind of care that they administer and quality and attention to detail, et cetera, that may affect some of these prognosis. There may be differences in that people who are too sick or crashing and burning may not get an echo or contrast to begin with in the first place. But I think there is a question of could there be an actual effect here on the diagnosis and diagnosis efficacy. We actually just presented an abstract back at the EACVI meeting, the European Association for Cardiovascular Imaging, that looked at people who got contrast versus with suboptimal image versus people who didn't, and looking at sort of mediation of mortality through LVEF. And we found that sort of EF, ejection fraction, is, as you would not surprise, very, very closely associated with mortality. If you had suboptimal image quality, the association between ejection fraction and mortality was attenuated. If you gave that person contrast, that restored that normal association. So it does suggest maybe there could be some direct routes in which getting the right diagnosis up front could ultimately be sort of causally related to the improved outcomes. But more work needs to be done.
Coming up towards the end here, I know Matt has some closing comments. Before we get to that, kind of one final question here, folks, I think people would be interested. What % of your patients undergoing ultrasound studies or echocardiography you use contrast in general? Joe, let's start with you.
So probably it's roughly about 10% of all examination in our department which go under contrast and ultrasound. And if I look at this 10%, around about 30% of this patient already had got MRI, CT, and sometimes they even recommend to check it with contrast and ultrasound.
Okay. Yeah, Casa, what percent of your studies do you use contrast agent?
We need to be a little careful in pediatrics. Remember, the pathologies that you frequently see, like liver lesions, are not very frequent in children, or the tumors and so forth that are very common and you do routinely contrast studies are not very common. Thus, if you take all that, we do, I think, a single-digit percentage of studies with contrast ultrasound in these children, because the indications are not there in the pediatric population, and we have far too many other indications where you don't need to use a lot of contrast, like maybe spinal ultrasound or even the brain ultrasound, where you use less of contrast. So that dilutes all that effect. But it's not the number that is important. What you have to think is these small numbers are the numbers that you're preventing MRI with anesthesia or sedation. That is the most impactful aspect of this. And that is not only a cost impact, but also significant workflow impact in pediatrics and in pediatric imaging departments. So I think we have to look at from a different perspective in children who have different prevalence of different pathologies.
Yeah, we probably do about 40% of our echoes with contrast. We do probably about 30,000 echoes a year, and about 40% of them get contrast. And we know that in the echo world, probably about 10 to 20% of patients have suboptimal image quality in sort of multiple different studies. It varies a little bit in terms of what population you look at and whether or not you're sort of a sick acute inpatient or a sort of healthy, well outpatient accordingly. But so we use it a bit more than that rate. And what we found is even in people without suboptimal image quality, we still find things. You'll find an apical aneurysm that you didn't know existed unless you use the contrast. So it's very interesting.
And that matches our lab historically as well, about 30% of studies for various